Thank you very much. It's a nice, intimate audience, people that really want to know about revision hip arthroplasty, so that's good. What I'd like to do is just share some discoveries that we've made over the last 12 months with our joint registry data. And basically we wanted to look at revision patterns across our joint replacement practice over the last 17 years. As you know, joint replacement, particularly in our country, and I'm sure in this country that will develop as well, it's certainly an epidemic. We have an ageing population. Not only do we have an ageing population, we have a population of aged who are very healthy. They have extremely competitive aspirations and increased expectations, and so we've got to address those as well. Stephen Kurtz talked about the prevalence of joint arthroplasty in the USA with these unbelievable figures of what the projections are for arthroplasty use in the future. And we have done similar things in New Zealand. The problem with the increased incidence of the index procedure is that revision rate also increases, and with this increases the socioeconomic impact of these revisions on the health economy of every country. These are our predictions, which we've taken from the New Zealand Joint Registry, and you can see that by 2018, knee replacements, which are in the red, will overtake hip replacements as the predominant operation performed, and the number of knee replacements will triple by 2030. The number of hip replacements will increase by 1.5 by 2030. So an amazing increase in the number of joint replacements, and already we see that these replacements are tracking along these graphs and these projected curves. So the implications for development of orthopaedic services is profound. So this study, we wanted to look at the first 15 years of the New Zealand Joint Registry to investigate whether the patterns of revision have changed over the 15 years. We wanted to see whether we've improved our standard of care, whether the reported advancements in orthopaedic surgery have improved our survival rates, and to identify any areas of perhaps improvement for the future. So from the joint registry, we took the data from 1999 when it started through to 2014, and we divided them into 3 5-year groups. And we looked to determine the overall changes for the cause for revision, compare the age and gender and ASA demographics, and also we wanted to look at early revisions, in particular those revisions done within the first year, to see whether there are any significant changes. If we look at our overall rates of joint replacement in New Zealand, the top 2 lines are the numbers of hip and knee replacements done in New Zealand, and you can see that they continue to increase exponentially as we predicted. The lower 2 graphs are the revisions, the numbers, the percentage of total joints done in our country in revision procedures. So there's the hips, which are increasing a little. So increase of the total number of joints done in New Zealand, 14% of them are revision hip replacements, and knee replacements tend to track along a flat line at about 7%. So if you look at those crude data, you say, well, things look pretty normal, pretty much what you'd expect to see. You're going to see this type of bar graph a couple of times, so I just want to introduce you to it. On the side here are the reasons for revision. This is what I talked about yesterday. When you look at joint registry data, you just can't take, yes, the revision for component X is such and such compared to component Y is such and such. That's raw data from the joint registry. Sure, it's good, robust data, but you need to delve into it deeper. You need to find out why these components are being revised. And so this is the revision causes listed on the joint registry for hip replacement. So this is the all-cause revision for hip replacement. And as you can see, as we go across the 3 5-year bands, that the instance of joint replacement, revision hip replacement is decreasing a little. Over the last 5 years, we've introduced a new band, which is this green band, which is metallosis, which is primarily associated with the metal-on-metal disaster that happened in our country and other countries. So we're going to kind of ignore that. So if you ignore metallosis, you can see that we're tracking down with our overall revision figures, and everything's looking pretty sweet. Here we go, here's the loosening of the acetabulum, here's loosening of the femur, and we can see that these are decreasing. So everything's looking pretty good if we look at the raw data like that. Things that we can say from this is that there has been a decrease in revisions for dislocations, almost certainly secondary to our increased use of larger heads. And also there's been an increase in revision for femoral fracture, infection and metallosis. What I want to do now is show you what our revision rates are within the first year, and you see a dramatic difference. I want you just to look at three areas really. The yellow area, which is femoral fracture, the red area, which is infection. Let's concentrate on the red area, because over the last 15 years, the infection rates have increased significantly. So this is revision within the first year. So the rate of deep infection has doubled despite our operative times, the use of laminar flow theatres and spacesuits, the use of antibiotic cements, everything's staying the same. Nothing's changed over those times. ASA 3 and 4 have increased the risk by 63%. Patients greater than 75 years had an increased risk compared to those under 55 years, and males were more likely than females to have infection. Femoral fractures also increased. This is probably mirrored by the increased use of uncemented stems, particularly in the early 12 months, so the early rate of femoral fractures has increased. We can talk about that if you wish. This is revision knee replacement. This is the overall cause for knee replacement again. Looking at all causes, and you can see the rate seems to be decreasing, but when we look at the rate for the first year, again, look at that red area on the graph. The red area is infection. And so infection for total knee replacements is increasing. So there's a significant increase in revision for deep infection. Those under 55 years had almost a 50% chance, increased risk, if you like, and males were 1.75 times more likely to have infection. Again, associated with ASA classes 3 and 4. So this is concerning for us, and our conclusions from our study are that the revision rates for aseptic loosening have decreased, which is a good sign. That means the things we're doing with our bearing surfaces seem to be improving the results for both hip and knee replacement. The rate of femoral fracture, which has increased in the early stage of joint revision, probably parallels our increased use of uncemented stems. But this is only significant within the first year. If we look at our results of cemented and uncemented stems out to 15 years, the rate of fracture of our stems after 1 year is exactly the same. So this seems to be an iatrogenic, an early problem with femoral fracture. Dislocation rates also have decreased, so another good thing, alongside the increased use of larger sized heads, 32 and 36 millimetres. But the worrying thing is that infection's still a problem with both hip and knee replacements, particularly in young males. And this is a concern for the future. Thank you very much.